Okay, well, good afternoon, everyone, and welcome to teaching for today. Today, I just wanted to go through basic sciences um, and physiology as it relates to pediatrics and child health, because many of you are doing the part one, and you'll be examined on that. And I thought, rather than go through clinical things today, we'd just cover a lot of basic sciences that are applied and related to common pediatric problems. So I'm going to try to address it in a way that um, is similar to the questions that be asked in the part one examination, and uh, and um, and address the basic sciences around that. If you were to construct a short answer question for these questions. So, firstly, let's talk about so we'll divide it into systems. So, talk about respiratory and cardiovascular physiology today. We might cover some other topics today or next week. But first of all, with respiratory physiology, I wanted to talk about a couple of relatively common problems that often arise in exams that you might be able to address. And you've already done some work on this in your part one assignments, but I just wanted to go over again how you'd construct an answer. So this is about asthma, the basic physiology of asthma and the pharmacological base. So I guess the first thing to say is that, as far as we know these days, it's an interaction between genetics and environmental stimuli that leads to an immunological or allergic reaction within the lung in susceptible individuals. And it's genetic. There's not one. It's not like Mendelian. There's not a gene that's definitely associated with asthma all the time, but it's polygenetic. There seems to be some genetic susceptibility. There's an allergic component, so there's sensitization and chronic exposure to certain allergens. They might be um, uh, house allergens within the household, or they might be allergens within the wider environment. And so, for example, when ryegrass is a common stimulant for asthma in some populations, allergic or sensitization to house dust mite, which is a small insect that lives within dust, often within if there's dusty or moldy areas within houses. Some children are allergic to sort of cockroach, you know, cockroaches or their droppings, and some children are allergic to animal dander, like the shedding of a dog or a cat. Some children are allergic to that. I mean, most children with asthma have an IgE-mediated eosinophilic response. That is, there's that sets up inflammation within their lungs, and that regardless of what their allergen that they're allergic to, or even if they're not definably allergic to any particular allergen. For many children that have food allergies don't necessarily have asthma. They may have anaphylaxis or urticaria, but there is a strong overlap between asthma and other and other allergies like anaphylaxis and urticaria, allergic rhinitis, etc. And mostly that's IgE mediated, immunoglobulin E mediated response that triggers eosinophilic production. Sometimes there's also a neutrophilic response in some children with asthma. Now, to go back to the immunology of asthma, there's broadly two types of remember, there's B cells and T cells, and there's broadly two types of T helper cells. There's T helper and T killer, but there's regard to different types of T helper cells. There's type 1 and type 2, and they're often called Th1 and Th2, and they produce a different sort of immunological response. The Th1 helper cells, they produce interleukin-2 and tumor necrosis factor, and they're mostly involved in an immune response to bacterial infection. Th1 responses are typically in response to bacterial infections or even parasitic infections. But Th2 responses, they encourage the production of interleukin-4 and interleukin-13, which in turn produces IgE, which is the stimulant for an allergic response and eosinophilic production, etc. Now, just to explain, IgE is just one of the 5 immunoglobulins. There's IgM, which is often the initial response, IgG, which is the more sustained response, IgD, IgA, which is the mucosal immunoglobulin typically, and IgE, which often triggers an allergic response. The immunoglobulins are produced by plasma cells, and they aid in immune reactions. So in patients who have a predominant Th1, that means they've been more exposed to bacterial infections and parasitic infections that often occur in sort of more rural environments, and they have allergy or asthma, whereas children that have a predominantly Th2 helper T helper response, they're more likely to produce cytokines and IgE that can lead to asthma. It's just important to know that in terms of as to why, to some extent, why in some populations there's more asthma than others. So Th2 responses, that is the cytokines that produce an allergic inflammation that lead to IgE and lead to activation. They're more common in with a Western diet, with urbanization, with exposure to house dust mite, for example, and also exposure to antibiotics. Whereas Th1 responses are more common in rural environments, exposure to bacterial infections, parasitic infections, etc. So, but the immune system does undergo a transition between Th1 and Th2 responses. But there are differences in the way children respond to environmental stimuli with their immune system. That means they're either more or less likely to develop allergy and asthma. Just to remember, it's the Th2 T helper responses that are more likely to lead to asthma. There's also a strong role of in asthma pathogenesis. There's a strong role of RSV, rare respiratory syncytial virus, and also other respiratory viruses. So while some children have definable allergic responses to environmental allergens, house dust mite, ryegrass, etc., many children just have asthma that's triggered by respiratory viruses. And the most common is respiratory syncytial virus. So we know, for example, that if a child has multiple RSV infections, or more than one even, throughout in infancy, then they're much more likely to go on and develop bronchospasm and asthma in the second and third year of life and subsequently. So sometimes those children are also more heavily exposed to other respiratory viruses, more heavily exposed to environmental conditions such as smoking, and sometimes they're less exposed to protective factors such as breast feeding, which has which is clearly a protection. It provides protection against asthma, and sometimes they're more exposed to antibiotics early in infancy. If they have RSV in early infancy and as young infants, then they may be exposed to antibiotics, and that can set up a more Th2 response. So that's really some of the immunology of asthma that you need to bring out in your answers. The other part of the question was related to the pharmacological basis for asthma treatment. And I just wanted to go through two things. One is the pharmacological basis for selective beta-2 agonists, and we use that. Salbutamol is a short-acting beta-2 agonist. There are other more longer-acting beta-2 agonists, which I'll talk about shortly. But beta-2 agonists activate adenylate cyclase to increase cyclic AMP, and that leads to relaxation of bronchial smooth muscle. It's more selective on bronchial musculature than it is on, for example, on cardiac muscle, which is more beta-1 response. So you just need to know beta-2 agonists are more respiratory selective on smooth muscle rather than on cardiac muscle. There are other things that beta-2 agonists do. They also decrease mast cell mediated release, so decrease the production of immunoglobulins and other cytokines. They may inhibit neutrophil or eosinophil and lymphocyte responses, particularly mucociliary transport of mucus. So there are mostly it's about relaxation of bronchial smooth muscle, but there might be also an immunological dampening down effect of beta-2 agonists. Now, increasingly, for the acute management of asthma, then salbutamol or Ventolin is typically the agent used, the drug used, but it's very short acting. And for prevention of asthma, salbutamol is not a good treatment for the prevention of asthma. It's good for the acute management, but it's not good for the prevention of asthma. So there are some long-acting beta-2 agonists which have been used for the prevention of asthma, and that means the child doesn't have to keep taking Ventolin multiple times a day as a prevention. If a child has chronic or persistent or recurrent asthma, then using a long-acting beta-2 agonist plus corticosteroids, and there's now combination therapy, which I'll talk about shortly, in a form called Symbicort. There are other names for it, but Symbicort is one form that's been endorsed by the World Health Organization recently. In terms of the pharmacological basis for steroid treatment in asthma, this is the question that was being asked, the pharmacological basis. Then the steroids obviously have a general anti-inflammatory effect, but how they do that is important, and how steroids act by changing protein synthesis within cells, and it's remarkable, really, the effect of steroids. They cause a transformational change within the nucleus. They upregulate specific receptor proteins, and they increase production of interleukins, which inhibit pro-inflammatory cytokines. So there's a number of different cytokines, interleukin 6 and 13 and 2, as I mentioned, that all lead to they're pro-inflammatory, and then interleukin 10 is an anti-inflammatory cytokine. So by changing the transcription of genetic of genes within cells, steroids can upregulate specific receptor genes that increase interleukin 10, which inhibit pro-inflammatory cytokines, and that leads to reduction in T cell activation, in mast cell activation, and eosinophil function. So steroids can do all that, and the important thing for like the physiology or the pharmacology of question is that they change the like all hormones, they change the translation and transcription of genes that lead to a different inflammatory response produced within the cell. And they do that very quickly. So I've mentioned before these idea of combination preventers, so long-acting beta-2 agonists and steroids. And previously the common preventer was a corticosteroid, an inhaled corticosteroid like budesonide, fluticasone, etc. And now there are combination long-acting beta-2 agonist and inhaled corticosteroids in the one metered dose inhaler, and one's called Symbicort, and there are other proprietary names for it. But it's a fixed dose combination medication. It's used for asthma in children or adults, and also chronic obstructive pulmonary disease, emphysema, etc., in where there's bronchospasm. It can also be useful in children who've got chronic lung disease from other mechanisms like chronic bronchiectasis or cystic fibrosis, or even in infants who've been preterm babies with bronchopulmonary dysplasia, if they've got some reversible bronchospasm or some excessive mucus production. And so these days, budesonide and formoterol is being used more commonly, and it reduces the amount of short-acting beta-2 agonists that children need. It reduces the amount of Ventolin that they typically need, and it can lead to a more stable state in their respiratory function typically. So budesonide is the steroid, the inhaled corticosteroid, and formoterol is the long-acting beta-2 agonist. And typically it's given once or twice a day. So children only have to take it once or twice a day. If their asthma is very bad, they'll take it twice a day. And if it's not so bad, they'll take it once a day. It needs to be taken every day. Although some children will take it for a season that's particularly bad that leads to their asthma, and some children will take it all year round. As I said, it's now on the WHO essential medicines list because it's been shown to be a more effective preventer than some of the other combinations. Short-acting beta-2 agonists could lead to side effects like tachycardia and other things, particularly, and the corticosteroids are more likely to lead to other side effects if they're used in such high doses. But the combination dose seems to be more favorable than using one or the other. Okay, right. So that's asthma, physiology, and pharmacology. Well, I want to now go through this question, a respiratory question, if you like. Explain the respiratory pathophysiological causes of hypoxemia. So there are really 5 causes of hypoxemia, and this is again applied physiology, but hypoxemia can occur because of inadequate ventilation. So if a baby is asphyxiated, if a child is immersed in water, if there's reduction in respiratory drive, then that will lead to inadequate ventilation. And ventilation meaning chest movement, the tidal volume or minute volume of the lung, and anything that leads to reduced ventilation will eventually lead to hypoxemia. Sometimes there's inadequate partial pressure of inspired oxygen. That's different. If you're breathing air that has a low partial pressure of oxygen. So, for example, at altitude, the partial pressure of oxygen is lower than at sea level, or if there's other gases in the environment that lowers the amount of oxygen that's in the environment, such as during a fire where there's a lot of other gases being produced that are toxic, and the oxygen level is quite low. So inadequate partial pressure of inspired oxygen is another reason for hypoxemia. The first 2 are quite uncommon causes of hypoxemia pathophysiologically. The next 2 are the most common causes of hypoxemia. So ventilation perfusion mismatching, which means that normally in the lung, the alveoli that are ventilated are well perfused with pulmonary capillaries. But if there is, for example, consolidation of the lung with inflammation within the alveoli, within the alveolar sacs, or there's inflammation of the bronchi, then there may be perfused areas of the lung, perfused lung tissues, that is perfused with pulmonary capillaries, that aren't ventilated. So the oxygen that gets into into the airways can't get down to the pulmonary capillaries. On the other hand, there can be ventilation perfusion mismatching if their pulmonary vein, arteries or capillaries have thrombosis, or if there's sluggish flow of blood through them. And for example, if there's a pulmonary embolus, then there may be aerated parts of the lung, but they may not be perfused. And so ventilation perfusion mismatching is very common. The most common example of that is in pneumonia, where you've got alveoli that are just full of inflammatory cells. And even though the lung is being well perfused, there's a mismatch between ventilation and perfusion. In a similar way, sometimes if there's complete occlusion of the alveoli with inflammatory cells or with pulmonary edema fluid, or then there will be right to left shunting. So the blood will flow through the lung from the pulmonary artery to the pulmonary veins without being oxygenated at all. And so that's intrapulmonary right to left shunting. Now, of course, there can be intracardiac right to left shunting, where instead of blood flowing out the pulmonary artery and then back through the pulmonary veins after becoming oxygenated, blood can flow from the right ventricle back into the left side of the circulation. So, for example, in a tetralogy of Fallot, where there is an obstruction to the pulmonary infundibulum and blood won't flow through the pulmonary artery, but it will preferentially flow back through the ventricular septal defect and out the overriding aorta, then you've got blood coming from the systemic veins that is shunted right to left through the aorta, and that is intracardiac right to left. And then sometimes in some circumstances, such as when you've got pulmonary fibrosis, especially pulmonary fibrosis or interstitial lung disease, there can be a diffusion defect. So even when there's disease of the interstitium of the lung, it may not be involving the alveoli, might not be involving the pulmonary capillaries. There's thickening of the interstitium, and that often leads to a pulmonary fibrosis and reduced pulmonary capillaries, and so there's a diffusion defect. So they're the five pathophysiological causes of hypoxemia. Inadequate ventilation, which can occur if there's reduced tidal volume or reduced minute volume, or a child might have a chest wall abnormality like a flail chest from trauma, or like a severe scoliosis that leads to inadequate ventilation. That is often a cause of inadequate ventilation leading to hypoxemia. Or if the child's not breathing enough oxygen because they're in an area of dense smoke, or they're at altitude, for example, or if they've got a VQ mismatching within the lung, they've got pneumonia, for example, or they've got a right to left shunting, such as a tetralogy of Fallot, or if they've got a diffusion defect from pulmonary fibrosis. So they're the five pathophysiological hypoxemia. You could think of lots of diseases that would cause hypoxemia, like bronchiolitis and like aspiration lung disease, or pneumonia, or sickle cell disease. But they all cause hypoxemia, but they all can be related back to one or more of these five pathophysiological causes of hypoxemia. Okay. The next question is to explain the respiratory pathophysiology of bronchiectasis. And we see bronchiectasis a lot, don't we? We see a lot of children who've got some form of chronic lung disease. And I just want to go through what the pathophysiology is. It's not the treatment or the clinical manifestations so much as just what happens to the lung when you've got bronchiectasis. And typically it occurs because of chronic infection of the bronchi, leading to a weakening of the bronchial muscular and elastic wall, and that leads to a dilatation of the bronchi. So it's chronic infection, chronic inflammation, and breakdown of the structure that supports the bronchial wall and leads to that dilatation. There's also, because of chronic infection and chronic colonization of the lung with often encapsulated bacteria like Klebsiella or Pseudomonas, there's increased mucus production and the cilia, which normally transports mucus back when it's produced, transports it up so it can be coughed out, is also impaired. So you've got cilial damage, you've got increased mucus production, and you've got a breakdown of the bronchial wall, leading to a saccular dilatation of the bronchi, and that all of that leads to uh, often a collapse of areas of lung that are distal to the area that's most affected, the bronchi that's most affected, or sometimes it can lead to sort of a emphysematous dilatation of some of the distal areas, and sometimes because of the inflammation, it can lead to fibrotic change within the lung. So it's the combination of all of those things. Ultimately, you get um, uh, sometimes pulmonary hypertension or hypertrophy of the bronchial vasculature, and that can also lead to bleeding and inflammation, and sometimes even rupture of the bronchial vasculature into the damaged airways, and that's why a child with bronchiectasis can have hemoptysis. It's because of the inflammation or hypertrophy of the bronchial vasculature. But the first three things are the most important. Weakening the bronchial muscle and elastic wall, saccular dilatation, increased mucus production, increased inflammation, and cilial damage and impaired mucus clearance. Of course, bronchiectasis can follow lots of different diseases. So it can be from recurrent or chronic pneumonia with tuberculosis, or pertussis, a chronic form of pneumonia, last for several months. Measles can lead to damage in the bronchial smooth muscle and the mucus production and the bronchial mucosal surface that can lead to this. Also, adenovirus can be a particularly damaging in some children who appear to be more susceptible. There are other children with bronchiectasis that might have an immune deficiency, such as HIV or such as a severe combined immunodeficiency. So there are some inherited immunodeficiency syndromes that lead to chronic infection, lead to chronic suppurative lung disease, and can lead to bronchiectasis. Recurrent aspiration is also a cause of these pathophysiological changes. And particularly applies to children, for example, who have cerebral palsy and have chronic colonization of their airways. They have recurrent aspiration, often microaspiration, or even aspiration of infected mucus from their nasopharynx or the retropharynx down into their lungs, and that can just lead to recurrent inflammation and infection. If they get exposed to a lot of antibiotics, then they'll get bacterial resistance within those bacteria, and that can all set up the in children with cerebral palsy or other neuromuscular problems who get recurrent aspiration pneumonia, that can lead to bronchiectasis. Inhaled foreign bodies are quite a common cause of bronchiectasis, and whenever we see a child who's got bronchiectasis, we should think, could they have a foreign body? And then there's some other primary inherited problems that lead to bronchiectasis. So of course, cystic fibrosis, which is the classic cause of bronchiectasis, but also a condition that's probably a bit more common than we realize, called primary ciliary dyskinesia, which is an inherited problem of where the cilia in the bronchial mucosa aren't functioning like they normally do, and they're not clearing mucus in the streamlined way that they normally do. And so cilia can be damaged. You can have secondary ciliary dyskinesia they can be damaged by any of these infections, so TB or pertussis or measles or adenovirus that can damage the RSV, even damages the lung cilia, and that's why one of the reasons chronic infection can lead to bronchiectasis. But there are some children that are born with primary ciliary dyskinesia, and that can lead to bronchiectasis. And cystic fibrosis, of course, can too. Okay. All right, that's enough for respiratory physiology. But again, you could go through any clinical problem and try to understand the respiratory physiology behind it. And that's, in a way, the part one examination will often ask an applied physiology question. So let's talk about cardiovascular physiology and see where we get to today. Well, firstly, list the causes of heart failure in children classified according to their pathogenesis. And I guess we think about heart failure, it's useful to have a way of thinking about heart failure. And this is a sort of way I think about it. If you think of all the different parts of the heart, that can help you understand the pathogenesis of heart failure. And so there can be either malformed or congenitally abnormal, or they can be there can be an acquired abnormality of the different parts of the heart. So the parts of the heart are the heart muscle, the septa, the ventricular septum, the atrial septum, the valves themselves, the pericardium surrounding it, the conducting system within it. So you can really understand the cause of heart failure by understanding the different anatomical parts of the heart. So let's talk about first of all, like in a order of relative commonality, I would say. So large left to right shunts are simply a defect within the septum, be it the ventricular septum or the atrial septum, or both the atrioventricular septum, or you can get a large left to right shunt if a child has a connection. So they've got a pathological connection between the left side of the circulation and the right side. And the most common one of that is patent ductus arteriosus, where you've got a persistence of a connection between the aorta and the pulmonary artery. And so that can lead to heart failure because of a large left to right shunt. There's more blood flowing through the pulmonary circulation than there is flowing through the systemic circulation. And because of the excessive blood going through the pulmonary circulation, that leads to pulmonary edema and pulmonary congestion and a strain on the right side of the heart, and also more blood coming back to the left side of the heart because there's been more flowing through the lungs. So a large left to right shunt, like a ventricular septal defect or an atrioventricular septal defect or a large PDA, is the most common cause of heart failure in young children, of course, isn't it? The second most, the next way of thinking about the pathophysiology or the pathogenesis of heart failure is if you've got an obstruction to any of the outflow tracts. So if a child has an obstruction to the left, particularly the left ventricular outflow tract, not so much the right ventricular outflow tract, that usually leads to cyanosis, but an obstruction to the left ventricular outflow tract anywhere along the pathway. So if at the outflow tract there's the aortic valve, before that's the infundibulum of the or the muscle just below the aortic valve, a subaortic stenosis, and then above that, above the aortic valve, you can get a coarctation, or the entire part, the aortic valve and the aorta, the aortic arch, can be hypoplastic, and that's a hypoplastic left heart syndrome. So you just need to know when all of these are a continuum from just having an isolated abnormality of one part, like a coarctation, aortic stenosis, to the more widespread hypoplasia of the entire left ventricular outflow tract or the aortic outflow tract, leading to obstruction. It can also involve the mitral valve. So the whole left side of the heart can be hypoplastic, and that can lead to obviously very life when the systemic circulation is entirely dependent upon blood flow from the right side of the heart going through the patent ductus arteriosus down the distal aorta. So we've thought about large left to right shunts. We've thought about left ventricular outflow tract obstruction. The other part is the valves of the heart. And so there's, if you think about that in pathophysiological terms, there can be congenital or acquired diseases of the valves. And I suppose the most important acquired diseases are rheumatic heart disease with acute rheumatic fever, or aortic that can lead to aortic regurgitation or mitral regurgitation, or there can be congenital aortic stenosis, which we've already talked about, or congenital aortic regurgitation, or congenital abnormalities of the mitral valve. But think in terms of valvular heart disease. Then there are types of myocardial injury. So it's not a hole in the heart. It's not an obstruction to outflow. It's not a problem with the valve. It's a problem with the heart muscle. And there's largely two sorts, again, congenital and acquired myocardial injury. And the most common acquired ones is as a form of myocarditis. Now, you can get that with acute rheumatic fever and immune-mediated myocarditis, and you can get myocarditis with other viruses. So with enteroviral myocarditis or other infections can lead to myocarditis. Sometimes with glandular fever, you can get a myocarditis. With influenza, you can get quite a severe myocarditis, inflammation of the myocardium that leads to impaired function, reduced systolic and diastolic function of the myocardium. This can occur in children who have systemic illnesses. They often have a very high fever. They present with failure, and that can be because of myocardial injury. There are forms of myocardial injury that are congenital, so cardiomyopathy, which there's many different types of cardiomyopathy. So there is dilated, and there's hypertrophic cardiomyopathies, and most of them have a genetic basis, usually not Mendelian inheritance. They're usually polygenetic in inheritance, but babies, and they're not always manifest in the neonatal period. They often take some months or even years to manifest themselves as a cardiomyopathy, because the hypertrophy has to become more and more prominent. For example, of the dilatation of the heart, they're babies that are born with weak heart muscles that go on to develop heart failure in infancy or childhood sometime. So that's myocardial injury. Of course, you can have direct myocardial injury from trauma that can lead to myocardial contusions, or and that also can lead to heart failure in direct trauma to the chest wall or to the heart. Then we think about pericardial disease. So we thought about left to right shunts. We thought about left ventricular outflow tract obstruction. We thought about valvular heart disease, congenital and acquired, and myocardial injury. But there's also the pericardial sac. So think about whether there's pericardial effusion with tamponade that leads to, or constrictive pericarditis that can lead to heart failure. That could be related to staphylococcal infection or related to tuberculosis, typically of there's some other inflammatory conditions like lupus and other things that can lead to pericardial disease. But typically, if there's a large pericardial effusion in tamponade, that leads to heart failure. And then, not forgetting again the other parts of the heart, the conducting system within the heart. So many different types of arrhythmias can occur that can lead to heart failure, like common ones in children, severe supraventricular tachycardia or atrial ectopic tachycardia. They're two relatively common ones that are sort of often incessant and continuous and can lead to heart failure in children. Of course, in adults and also in children, there can be ventricular arrhythmias that lead to heart failure, often leading to shock or cardiac arrest. But the common one in children is supraventricular tachycardia, that where babies present in heart failure, they're often very pale. They have extreme tachycardia. So when you're seeing a child with heart failure, you can go through this sort of pathophysiological list and think then what could be the underlying cause. And then there's a group of conditions that can lead to high output heart failure. So there's nothing wrong structurally with the heart. In fact, the heart's all quite well, but it's having to work even harder than it normally would. And so there are some forms of, certainly with high output cardiac failure can occur with severe anemia. If you've got a hemoglobin that's very, very low, like 2 or 1 gram per deciliter, then that can lead to very severe heart failure. And it often, to start with, leads to high output heart failure, and then the heart muscle fails because the heart becomes too dilated, and on the Starling curve, there's then low cardiac output, and that can present, those children can present in heart failure when their hemoglobin is less than 4. So that's why we transfuse patients with a hemoglobin less than 4 or 5, just to prevent them going into high output heart failure, which ends up being low output heart failure. Then there's some nutritional cardiomyopathies. These are acquired cardiomyopathies, often like cardiomyopathy, such as with beriberi, and other nutritional abnormalities that often micronutrient deficiencies that can lead to high output heart failure. It's always high output to start with, and then typically it becomes low output. There are some other forms of high output heart failure, like AV malformations. If a child's got a large AV malformation, then their heart's having to pump much more blood to perfuse the rest of the body, and the AV malformation can be, could be a quarter of the take up a quarter of the cardiac output, and that can lead to high output heart failure. Over time, the heart just fails because it's the muscle function, everything has to work harder than what it did before. And then there's heart failure that's secondary to lung failure. And if you think about it, anything that leads to severe pulmonary hypertension, be it chronic lung disease or acute severe pneumonia, puts a stress on the right ventricle, and that in turn can lead to, because the right ventricle is a weaker ventricle, it can lead to a dilatation of the heart, to a leftward shift of the septum, the interventricular septum. It leads to reduced filling of the left ventricle during diastole, and therefore reduced stroke volume of the left ventricle. So that's what happens when you've got cor pulmonale, which can either, we think of cor pulmonale as in adults who've got in emphysema, but you can see cor pulmonale in any child who's got severe chronic lung disease with pulmonary hypertension, with right ventricular dilatation and heart failure, and leading to reduced left ventricular output because of a distortion of the septum and etc. So I think the point of this is that you can go through the types of heart failure in pathophysiological terms, and then you can think about the different conditions that might lead to that pathophysiology. That's what I've tried to demonstrate here. Large left to right shunts, left ventricular outflow tract obstruction, valvular heart disease, congenital or acquired, myocardial injury, inflammatory, congenital, nutritional, pericardial disease, often infective, typically,
arrhythmias leading to a problem with the conduction system, leading to heart failure, high output heart failure because of anemia or nutritional problems, or sepsis can lead to high output heart failure, or AV malformations, and then heart failure that's secondary to lung failure, so-called. Okay, we'll do one more. I think that in terms of cardiovascular physiology, explain the different types of shock, their pathogenesis or their pathophysiological. And I think this would be a common question in the part one, and something that we see regularly enough to need to understand the pathogenesis of shock. And you can break shock into a variety of different conditions. We've talked about heart failure before, but shock is a bit different, isn't it? Because it involves the whole circulation, not just the heart. And so shock can be, of course, hypovolemic. If you were to answer this question, you'd have to mention all these different types of shock. So hypovolemic shock, which could be because a child's lost blood or because they've become severely dehydrated. Children can lose up to 30% of their blood volume and not go into shock. They have lots of corrective mechanisms for that: tachycardia, increased stroke volume, particularly vasoconstriction. But beyond a certain point, the child will then go into shock. And if they lose, if a child's more than 10% dehydrated, then they're likely to be in shock. So certainly 15 or 20% dehydrated, they'll be in hypovolemic shock. Despite those protective mechanisms of tachycardia and increasing stroke volume. And then there's the things we've talked about before. If you were to answer this question about the pathophysiological basis of shock, then the pathophysiological causes of heart failure all become relevant here. So cardiogenic shock can be because of all of those things we mentioned: left to right shunts, outflow obstruction of the left ventricle, valvular heart disease, myocardial or muscle problems, pericardial disease, or conduction abnormalities. They can all lead to cardiogenic shock, but usually that a child will present in heart failure rather than in cardiogenic shock. Cardiogenic shock is a much more extreme form of heart failure, isn't it? But hypovolemic, cardiogenic, and then there's another type of shock which is a bit mixed in terms of the different causes, but it's often called distributive or vasoplegic. And in the there's three. I'll give three examples. The first one is sepsis. So in the early stage of sepsis, you've got often a relative vasoplegia, and that occurs because of many things. One, the hyperinflammation that's going on. Two, because of from lots of other mediators leading to vasodilatation. And so this is often a high output form of heart failure. With sepsis, the child is tachycardic and has their look at the echo. Often the heart appears to be working overtime. They've got increased contractility and increased stroke volume, and that then ultimately gives way to often low output heart failure, low output shock, where the child then becomes vasoconstricted and cold. But in the early stage of shock, there's a form of vasoplegic distributive high output shock where the child's often warm, they've got bounding pulses. On echo, it looks like their heart's functioning very well, and that that can be a sustainable state. But if not treated properly, if the inflammation is not got on top of, excuse me, that can lead to a low output state. Anaphylaxis is another form of distributive or vasoplegic shock where there's a widespread immunological reaction to an allergen that leads to and leads to shock. So often those children also will have bounding pulses. They'll have a wide pulse pressure. They may feel warm to start with, but their blood pressure will be low, and ultimately they may, unless it's treated with adrenaline, for example, they may go into extreme heart failure or more advanced shock if not treated properly. And then lastly, as I said, there's broadly three different types of causes of a distributive or vasoplegic shock. And the third one is children who've got a spinal cord injury. And it's very common in children with a spinal cord injury after trauma get because our blood vessels rely on the vasoconstriction that occurs from the not only circulating catecholamines but also neuronal input leading to vasoconstriction. That is nerves that come from the brain and the spinal cord leading to vasoconstriction or vasoreduction. When the spinal cord is damaged, then it obliterates that nerve, those autonomic nerves that go to the blood vessels, and then you get a form of vasoplegic shock, which means there's the blood vessels can no longer constrict to other stimuli, so they are just vasodilated, and then often there's also bradycardia with it because there's a lack of sympathetic stimuli to the heart to tell the heart to go faster. So that combination of bradycardia and vasodilatation leads to vasoplegic shock in children who've got in children or adults who've got a spinal cord injury. Usually this spinal shock does settle down after a period of a couple of days, usually after children have a spinal cord injury, but there's an initial period of spinal shock which needs to be managed appropriately by increasing sometimes by using some vasoconstrictors like noradrenaline or adrenaline that would stimulate the heart to go a bit faster. And then there's some other agents that children who've got a spinal cord injury can go beyond longer term. If you don't have adrenaline or noradrenaline, then sometimes using aminophylline, for example, can help make the heart go a bit faster for a while. There's different ways you can manage spinal shock, which we don't have time to go into today. But I think obviously the common forms of shock are hemorrhagic and hypovolemic from gastroenteritis or severe sepsis, and cardiogenic shock from all of these reasons. They're the most common causes of forms of shock. But you can think about it in terms of hypovolemic or cardiogenic or distributive shock. I think we might stop there and perhaps have we might continue this next week. I'm going to just stop. Yeah, okay. All right, well, I hope that sort of thing is useful to you to go through some of the common pathophysiological changes that are behind common clinical features that we see, common clinical problems in the part one. That's the sort of thing that you'll be asked to do. There'll be questions that are just such as I posed today, outline the pathophysiological basis or the immunological basis for HIV, for example, or the pathophysiological basis of type 1 diabetes. We'll go through them a bit more each week, but today we've just touched on the respiratory physiology and also some aspects of cardiovascular physiology, but we'll do a bit more in the weeks to come. I just wanted to cover those things off so that you, one, are able to be better prepared for the part 1 examination that's coming up in 3 weeks, and also be a bit more knowledgeable about the sort of the pathophysiological basis of things that we see every day. So I'm just going to stop the recording now, and happy to answer any questions that you might have.